All right, so good evening, everyone, and thank you for joining us. My name is Eliana Landa, and I'm the Physician Relations Specialist here at Rothman. Tonight's webinar is with Dr. Bornstein, foot and ankle surgeon. His office locations are in East Orlando and Winter Park, and the topic that he will be covering this evening is what you need to know about big toe joint surgery. So just a few quick notes at the bottom of your screen. You will see a Q&A icon where you can enter any questions that you may have throughout the presentation. Dr. Bornstein will have time at the end to answer any questions as he can. And also in the chat box, I will share Rothman's phone number if you would like to make an appointment, as well as my information if you need any assistance. The webinar is being recorded and you will all be emailed the recording within a few days, I'm sorry. So without further delay, I will pass this off to Dr. Bornstein. Welcome, Dr. Bornstein, and thank you for your time this evening.
Thank you, Ileana. And thanks for everybody for taking the time to be here tonight. So as Ileana referred to, this is, I think on your invite, it's big toe surgery. The fancy name for that is first metatarsal phalangeal joint surgery. And so I think tonight what we'll do is we're going to talk about the first metatarsal phalangeal joint and some of the more common issues that can occur and the surgical choices as far as correcting these issues. So, you know, what we have here are a couple of pictures of, you guessed it, big toes. So there's two basic deformities that we see at this first metatarsal phalangeal joint. And they essentially occur in two different planes. And I think the picture on my right of the lady with the red toenails kind of gives a demonstration of both of them. If you look at her left foot, what you will see is a foot that's gotten a little bit wider and a big toe that has started to move over towards the second toe. And that's what we would refer to as a bunion deformity or a hallux abducto-valgus deformity. On her right foot, you see a toe that looks relatively straight. The deformity in this situation is what we refer to as hallux limitus or hallux rigidus. And that is a function of how much motion is still available at the toe or how much is lost. So those are the kind of the two big deformities that we see here. And if you look at the other three pictures here, what you'll see are kind of the things that you see associated with this. You'll see enlargement of that big toe joint, either on the top of the foot or on the side of the foot, what we call the medial side, the part that would push into the into the shoe. We also have varying degrees of limitation of motion associated with this. So with that, let's kind of take a little more in-depth look at what's going on. So let's see if I can make my slide advance. Oh, there we go. So when you look at the structural pathologies, I kind of talked about it before. On your left there is what we would consider a normal alignment. So sometimes it's helpful to think of your hand when we think of our foot, in that the toes are very analogous to our fingers, right? And the big toe would be analogous to our thumb in that it is typically, you know, made up of two bones, just like your thumb, and the smaller toes are made up of three, like the smaller finger, or excuse me, the lesser fingers. So the normal alignment of the big toe, as you can see here, we have what are called metatarsal bones behind the toes. So if you think again about your hand, if you put your hand up here and you grab a hold of your knuckles, that is what we would refer to as the metacarpal heads. In the foot, that becomes the metatarsal heads. So that's kind of the joint we're looking at here, is that metatarsal phalangeal joint. So there is a normal angle between the first metatarsal and the second metatarsal, and that's typically something less than about 9 degrees. As that angle increases, we start to see that bunion deformity that you see on your right side. That angle increases The result is the big toe starts to move closer to the second toe, and the foot literally gets wider. So you start to see that bump on the side, and that area is typically where we see our first discomfort. And what you're getting is the foot's getting wider, and that side of that big toe joint is rubbing in shoes. Right underneath the skin, there's a thin layer of fatty tissue, and in that fatty tissue are two sets of nerves and vessels. And as that big toe starts to drift over, that area becomes more prominent, and now those neurovascular bundles are more apt to rub on the side of the shoe. And that's why that first pain is typically what we refer to as bump pain. As this deformity progresses, over time, you can start to get some degenerative changes in the joint. And now that pain profile typically changes. And now you start to get pain that is not necessarily only there in shoes, but can be there when you're not in shoes and is more related to the motion of that toe moving up and down on a joint that started to wear out. Okay, so let's move on to our next slide. Okay, now we talk about a deformity where we don't see an increase in that angle between the first and second metatarsals. What we see is, at any rate, we're talking about hallux abductor valgus before, and now we're talking about something that's referred to as hallux limitus, or ultimately hallux rigidus. And what happens here is, rather than the angle between that first and second metatarsal increasing, we get instability in what we call the medial column, which are all the bones that come from that big toe all the way up the side of your foot. And that metatarsal, that first metatarsal, starts to move up and down more than it should. And what occurs is, when you step down, so kind of like the picture you see at the bottom, when you step down, the big toe doesn't move like it's supposed to. And the reason for that is the motion at that joint is not a hinge like your door or your elbow or your knee. What has to happen is that first metatarsal head has to stay stable against the ground while the base of that toe, which is kind of cup-shaped, glides up over the top of that metatarsal head. And so if you have instability of that first metatarsal, where that metatarsal head can move up and down when you stand on it, initially what will happen is you will start to have decreased motion when you're standing on the foot. When you pick the foot up and you try to wiggle the big toe, you've got plenty of motion. And so for some people, this continues over time. And what will happen is you will start to build up bone on the top of the first metatarsal head. And when that occurs, now you start to get a physical limitation of motion at that joint. And when that occurs, it starts to put pressure on the top of the joint surface from compression. And over time, that starts to wear down the quality of the joint cartilage. And the result is pain. And so, initially with this, you have motion, and it's not typically painful unless you're on your feet for a long period of time, and then it'll get better. As it progresses and it starts to become a structural limitation of motion, then you start to get more consistent pain. So let's take a quick pic here. So when you look at what do you do with people who have either a bunion deformity or hallux limitus or the hallux rigidus, and you say, from a surgical standpoint, what do we do? And more importantly, how do we know when surgery is appropriate, and how do we know when it's not appropriate? And I would tell you that my basic, benchmark for this is pain. And, as you see on the slide, I would tell you it's pain that begins to impede your ability to do the things that you like to do on a regular basis. And you can't do that because of pain. And you have tried basic non-surgical treatments such as arch supports and anti-inflammatory medication and shoe modifications. And unfortunately, you're still having pain. Now, there's one group that is not the benchmark, and that's a small group, and that's people that have decreased sensation. Most typically, those people these days, we see them as diabetics. And the reason for that is that increased pressure in either the top or the side of the big toe joint can be put them at higher risk for ulceration, which can end up in wounds and infections. So absent neuropathy, I would say that the primary surgical indication is pain that inhibits your ability to do the things you like to do, whatever that is, okay? So we're going to start talking about, well, we've made a decision as to, surgery is appropriate. So what are we trying to do? Well, it depends upon the type of deformity we have and where you're having your pain. So the first thing that we talk about is your pain on the side of the joint or is it in the joint? And the difference is, I think we touched on it earlier, is your pain primarily in shoes or do you have pain when you're not in shoes? Is the pain when you move the joint or is the pain primarily when you push on the side of the joint? So that's the first thing that we want to look at. The next thing we want to look at is, well, what plane is that deformity in? Is it in the case of a bunion deformity? Is it in what we refer to as, kind of the transverse plane where the foot gets wider? Or in the case of hallux limitus or hallux rigidus, is it that metatarsal is unstable and it's moving up and down and up and down? And the reason for that is when you go to correct these deformities, in large part, you're looking at reversing those changes that have occurred. In the case of a bunion deformity, we want to decrease that intermetatarsal angle. In the case of hallux limitus, we want to stabilize that first metatarsal. So those are the first things that we kind of look at. So when you look at deformity correction, let's start with a bunion. So we kind of talked about the increased intermetatarsal angle, the widening of the foot. You can see it in that far left picture. We've got a big increase in that angle. We've got the toe kind of subluxing laterally. Those little bumps that you see kind of underneath that metatarsal head, those are called sesamoid bones. And they should sit directly up underneath that first metatarsal head. So if you think of sesamoid bones, probably the analogy that you would kind of understand is, think of it as your kneecap. These are two little disc-shaped bones that sit underneath that metatarsal head, and they glide back and forth as you bend that big toe up and down. So part of this deformity where we get this increased intermetatarsal angle is sometimes we get some rotation of that metatarsal head, and it'll cause those sesamoids to move out towards that interspace. So we have to be mindful of that when we're looking at how do we correct this. So when you look at how to correct this, once that intermetatarsal angle has increased, then we want to decrease it and get it back down below that 9 degrees or less to get the toe to want to straighten back up. So depending upon how big that angle is, determines where on that metatarsal we can address the deformity. If you look at the picture to your left, that angle is significantly higher. Without measuring it, I would say it's probably on the order of 20 degrees or more. So in order to bring that metatarsal over, we had to go back to the back of the metatarsal where the metatarsal cuneiform joint is. We actually ended up fusing that joint to stabilize that first ray and to bring that toe back in alignment, or to bring that intermetatarsal angle back in alignment. And as you can see, the result is the toe drifted back over. For a deformity that is not as big with respect to that intermetatarsal angle, sometimes we can work closer to that big toe joint. And as you can see there, you see the two little screws in there. We were able to make a cut closer to the joint itself and push that metatarsal head over and then secure it with the use of the screws while your body knits that back together. So that the takeaway from this is, when the joint is not really arthritic, we can work to just reestablish that normal alignment of that big toe joint. Okay, so let's see what we have next. So when we're talking about hallux limitus or early stages of hallux rigidus, where, as you can see where that arrow is on your left, you can see that big bone spur. So in this case, this is someone who had pain because now you can see that spur. Well, physically, the base of that toe can't get past that spur. And so it limits motion and it causes pain in the joint from the compression of the base of the toe on that metatarsal cartilage. Well, in this instance, the overall joint surface was pretty good. And so the idea is, can we just increase that range of motion, and will that in and of itself allow us to get rid of the discomfort? So what you see underneath that second picture there, we literally just went in and took that spur off, and in looking at the joint surface, felt like, what, that's good joint surface. And the first ray was otherwise relatively stable. And so we did what's called a chilectomy. And so that getting rid of that spur allowed us to get motion on an otherwise good joint. If you look at the picture to your right, it's somewhat similar, but you'll see there's a screw there. And sometimes what happens is not only has that spur developed, but because of the motion of that first ray, we actually take that metatarsal head and move it down several millimeters, again, to kind of open up that joint and allow for motion. Now, these are referred to as joint sparing procedures because the overall joint surface is still healthy and we can still work with that. If we were to leave that and not do anything with it, over time, these are typically the joints where you start to get arthritis and wearing on the joint surface, okay? So when we get to the point where we say, what, that joint has worn out, and now the pain is primarily in the joint, meaning the pain happens when we move the joint up and down. If you clean up the bone spurs and you otherwise realign the joint, you're still likely to have pain because you're moving that base of the phalanx on a worn out joint surface, and so it's gonna hurt. So we have to find a way to make that better. And so you basically have two kind of choices with this. When you have an arthritic joint, on some joints, not all joints, you have an option. And that option is we can fuse the joint, because if the joint doesn't move, then we're not going to have that friction across that worn out joint surface, and you won't have pain. In some joints, and the big toe joint is one of those, we also have the option of replacing that joint. We put some kind of artificial joint, or years ago it would be more of a spacer, but the concept is the same. We get rid of the worn out joint surface, and we give you a new surface to move across. So the difference being you maintain the range of motion, but you eliminate the pain associated with that motion, versus what you see on the far right, which is you fuse the joint where the joint doesn't move. And so I think, probably the obvious question is, well, how do you determine which one of those is the appropriate procedure? I think, both of these procedures long-term work well from the standpoint of getting rid of pain. I think for some folks, and this is a discussion that we have with all our patients, we talk about the pluses and minuses of fusion versus joint replacement. And then we let the patients tell us what they think works for them. The older joint replacement surgeries had a pretty good failure rate from the standpoint that we were taking a joint, originally joints that were designed for fingers, and we were putting them in a big toe. And to be honest, the motion wasn't the same. And so those joints tended to break down. They were made of hard plastic or celastic. And over time, they would break down. Now, for some people, that meant that you had inflammation and you had to take the joint out. For other people, that joint may look bad on x-ray, but they would tell you that it worked rather well. But when those were the joint replacements that we were working with, I would argue fusion probably on a longer term basis made more sense, because once the joint was fused, it was stable and it tended to work well. Newer implants that are not necessarily even new now, the newer generation are probably a decade or so older, are now more anatomically correct, if you will, for that first toe joint. They're two-piece implants. So it's not a single implant with a hinge. It is a two-piece implant, and that allows for a more normal motion. That allows the base of that proximal phalanx to ride up over that metatarsal head. And so it's a more natural motion. So when we talk about the decision as to what to do, I would argue that getting motion is probably better than fusing a joint. However, there are some people that have been functioning for a very long time with very limited motion, so they were almost fused themselves, but it's painful. And so for those people, they may tell you, you know what, I haven't had any motion in that big toe joint for years. It's just that it hurts. And for those folks, they may opt for fusion. Again, pain relief is why you do this. And I think you can make a case for either one of these, but it is a discussion that we typically have with the individual patient and talk about activity and what their expectations for post-op. So, oh, look at that. We ran out of slides. So let me see if we can look here, and let me see if we have any questions.
Can you see the question?
I sure do.
Okay.
Is exercise effective in delaying surgery? I would tell you this. I would always tell people that exercising and certainly range of motion is important. I would also tell you that you're best doing that in a shoe that helps to stabilize your foot. And what I mean by that is most of these issues that we've talked about, without getting into the depths of biomechanics, have a lot to do with kind of instability on that medial column. And so on one hand, I would absolutely tell you that I'm all for you doing as much exercise as possible. I'm all for doing any kind of strengthening exercises to help strengthen the intrinsic muscles and all of that. But I would encourage you to make sure that you're doing that with a good supportive shoe, one that's properly fitted. Probably even go so far as to get yourself a good rigid over-the-counter arch support, okay? And what I mean by that is probably something a little more stable than what you would see at, a Dr. Souls or something like that. But I would also caution you about over-the-counter arch supports. I would give you this advice. There are some very good ones out there. We can probably share some ones that you can get on Amazon that are quite effective. Please do not go and spend hundreds of dollars on an arch support. Don't go to the mall. Don't let somebody tell you that you need to spend hundreds of dollars on an arch support. You can get a good rigid over-the-counter arch support in the neighborhood of $30 or so. And I would tell you, if you go someplace and they're trying to give you an arch support and it's hundreds of dollars, you are probably wasting your money. You're not going to get anything better than what you could. Now, that's a little different than a custom-made arch support where you're actually casted for it and all of that. But even with those, I think most people can get away with a good rigid one. And I would say, hey, start with that, because if it works for you, you've probably saved yourself a lot of money. And if it doesn't, you can always consider something that is a custom. I would also, in these days, I would tell you, if you're going to be out there moving and exercising, there are a ton of really good athletic type shoes. And I would tell you, I don't get into the weeds of telling you, should you get a Hoka, should you get a Brooks or an Asics? And the reason is because those shoes, I believe, are nuanced to the point whereby some are actually better for people with a flatter foot. Some are better for people with a higher arched foot. Some are better for people that may have a little tightness in their Achilles tendon. So there are a couple of places in town here. I will be more than happy to give you the names. I will tell you, in Orlando, I would look at Track Shack or Fleet Feet for a couple of reasons. Number one, they will take the time to really make sure you should get properly fitted. And more importantly, because of their typical clientele of runners and people that are really exercising a lot, they realize that, hey, you know what? Maybe this feels great in the store, but a week later you come back and you say, hey, this really isn't working for me. And I think they're okay with you coming back and saying, let's look at this and figure out what might be better. At least you want to start by saying, hey, I have a shoe that's not going to work against me. Okay. Will a joint fusion due to osteoarthritis straighten a bunion deformity? Yes. When you fuse a joint, you can put that joint wherever you want. And so that's kind of with fusing it. Yes, if you have a bunion deformity and you have arthritis, we do fuse those sometimes. But yes, when you fuse a joint, you can put it literally wherever you want. Depending upon how bad that bunion deformity is, specifically how high that intermetatarsal angle is, you have to take into consideration that that's not going to narrow the foot. So there are some discussions about perhaps ancillary procedures that might be done with that. But absolutely, if you fuse it, you can fuse it and straighten it out. What can I do for hammer toes where I'm always hurting on the tops of my toes? Great question. So here's what I would tell you. The first thing that we always recommend is be very aware of the forefoot area. So that's the part of your shoe kind of where the base of your toes start. You want to make sure that that is wide enough, but also, is it the toe box deep enough? A lot of times when you're having pain on the tops of those smaller toes, those hammer toes, it's because they're hitting the top of your shoe. And so you'd be surprised how many times if you just go with a deeper toe box, that allows room for those toes to move about and not hit the tops of your shoes. So I think that's a good place to start. Okay.
I think we have one more question.
Sure. No, I got it. So joint fusion at this time, one of the things that has occurred over the years is our fixation choices are more robust. And as a consequence of that, early on when you would fuse a joint, we were using pins or 1 or 2 screws, and you need to keep that joint still because it can take 12 weeks or so for that joint to fully fuse. Some of the newer hardware, one of the benefits of them is that they're very rigid and you can get good compression on your fusion site, and they do allow for you to bear weight sooner. In the case of the one that you saw on the bunion, where it was back at that metatarsal cuneiform joint, with that type of a procedure, we typically allow our patients to bear weight in the first couple of weeks. The big toe joint, probably in the same range, maybe a couple of extra weeks, depending upon the quality of the bone and the stability of the fusion itself. But that's the purpose of the hardware, is to hold that those two bones in place while they knit together. Once that joint has fused, in reality, your hardware has no purpose. And sometimes we'll elect, if it's a problem for the patient, to take the hardware out. But if it's not a problem, then we leave it in place.
Great. So I think that wraps it up with all the questions, Dr. Bornstein. So thank you all for taking time out of your schedule to join us this evening. And thank you to Dr. Bornstein for sharing such valuable information. I hope you all found this information helpful. And if you still have any questions, please feel free to email me, which you will find in the chat box, and we will get back to you as soon as possible. Again, if you would like to make an appointment, please call 1-844-407-4070. Or you can go to www.rothmanortho.com. Thank you.
Thank you all. I appreciate you taking the time to be here with us tonight.